question actually we want to ask it's about Dr. Ye and Dr. Malard. We know, just like Dr. Zhao Yanming shared, we know about into the how do you integrate into the optimization of the hematologist stem cells transplantation clinical treatment system with the bridging strategy using targeted or cellular therapy to overcome treatment resistance and improve long-term survival. Actually, we want Dr. Ye and Dr. Malard to share your own opinion about. We can know the Chinese and the Europe, we have the different strategies. Thank you so much. Maybe we should have Dr. Malard to share your opinion about this question.
So thank you. This is not an easy question. So of course we saw all these advances. I think that the first things to improve this is regarding the patient selection. Of course, we have also all the things now we know about the treatment driven based on the MRD for the patient selection. And based on that, we have to build the best bridging strategy. Of course, when you go to acute lymphoblastic leukemia, you have access to the CAR T cells now. For acute myeloid leukemia, this is more difficult, the access for the CAR T cells. But of course, in the future, and this is what was demonstrated with this great paper from Professor Wang with the CD7 CAR T cells, I think this is really going to be the future as approaches for those patients with some sequential approaches, with some targeted CAR T cells, followed by some stem cell transplantations that will negative the disease burden before the transplantation. And in particular, if we don't need some high-dose immunosuppressive treatment, it will clearly improve the patient outcome, less graft-versus-host disease, less disease relapse, and we really should move for that.
Okay, I think very much Professor Malard. I think I fully agree with Professor Malard's opinion. I think we already in a new era of transplantation. Take myeloid leukemia as example. We have now more and more small molecular antibody, small molecules like IDH1, IDH2, FLT3 inhibitor, and many inhibitor. And there are already preclinical data and clinical trials ongoing to test these new drugs before and after transplantation as maintenance. For example, for FLT3 inhibitor, which we have previously we have sorafenib, and now we have geritinib, and we have quizartinib, which already show very promising data before and after transplant. And we know that instead of intensive chemotherapy, we use venetoclax-based therapy, and these small molecules, we have more and more patients, especially elderly and previously thought unfit patients, to go into the process of transplantation, and afterwards we can do the maintenance. And it is very important to see that because Professor Mark Lewis just published the data in JCO in 2025, and also some new data of last year's ASH meeting, that we can also decide to do the maintenance or not, depending on the MRD before and after transplant. So I think, and of course, for the CAR T bridging to transplant by Professor Huang, Professor Hu, we can have more patients to go to transplant even without GVHD prophylaxis and the conditioning regime. And because the CD7 CAR T will not only make a very good conditioning regime, but also control the disease after the transplant. And then we can see a very good disease control afterwards. So I think the future is on the new targeted therapies, not only the small molecules, but also CAR T cells and integration of immunotherapies like blinatumomab, for example, to eradicate the disease before transplant, to do an EDA transplant, and to do maintenance the disease maintenance after transplant with these new strategies. So I think it is very promising. Thank you.